Welcome to the Low Carb MD podcast. No one is beyond help. No one is beyond hope. Nothing said on the Low Carb MD podcast is medical advice. Please consult your own doctor before making any lifestyle changes.
Hello and welcome back to the Low Carb MD podcast. Today we have a smart kid here. Yeah, we usually don't let Ivy Leaguers here, but we're going to make an exception since you went to Yale. We'll let you come in and educate us a little bit. A youth pastor, you've done it all. Youth pastor, physical therapy, and you're focused on cholesterol and making it so that people can understand it. So how did you come down this road? How did the Lord lead you down this road?
Yeah, I have been so blessed to have many opportunities and many circuitous situations that have led me here. And you know, I've done the youth ministries at our church outside of Boise, Idaho for the last 13 years. That's actually interesting because that's the one thing I didn't go to school for, but it was just where God wanted me, and that's a cool thing there. But basically, the first time I went to grad school, I went for physical therapy school. And God uses even adverse situations to catalyze our paths and what we're supposed to do when we grow up. And so I got really, really sick, actually. And I was a Division I track athlete and got really sick, and no one could really figure out what was going on. And so I was like, well, you know, this stuff's kind of interesting, even though it's miserable. So let me see if I can figure it out. So that kind of got me falling in love with biochemistry and endocrinology. And but anyway, but at that point I finished up PT school, and I just never had a sense of finality that was it. And it was a huge blessing to work in outpatient orthopedics and even neurological rehab with people who had Parkinson's and MS and other things like that. And so being a PT is great, but I knew that wasn't just the end for me as far as schooling goes. And so I was like, okay, well, you know, the quickest means to my end to hopefully help people with their endocrinological disturbances and rid the world of metabolic dysfunction, which, you know, or at least help them, was to go to PA school. So I went to the Yale School of Medicine for PA school, and that was very, very enjoyable. And then I was practicing in endocrinology, and I had a patient cancel one day, and I'm always reading stuff. I'm a voracious reader, and there was proteins, something obnoxiously condescending like that. And I'm like, okay, well, you know, I'm pretty good at biochemistry here. You know, I'm a big pentose phosphate pathway guy, you know, and if I had a motorcycle, you know, I would call it Krebs. And so anyway, so I was thinking, okay, how hard can this stuff be? And I read this article that's supposed to be just this rudimentary review of lipids and lipoproteins, and I barely understood any of it, and it made me mad. So I was like, all right, well, that's unacceptable. So anyway, I wish I had some sort of humanitarian reason to get into lipids, but that's why. So I start just pouring myself into everything I can find as far as lipidology goes. And then I took the Clinical Lipid Specialist exam. So I'm a board certified lipid specialist along the way. And then I couldn't help myself because I have very few useful skills except going to school and taking tests. And so I was working on a PhD during that time as well, studying cholesterol disturbances, Alzheimer's disease, and I completed that in 2024. And so anyway, all these sorts of situations, and I left out a bunch of stuff too, but I've been very blessed to, you know, learn some stuff along the way and hopefully be able to convey that in a way that makes sense to people, because lipids get so complicated, and I learn stuff every day about lipids. But one of my goals is always to walk with kings, but not lose the common touch. Because, you know, I try to have a truly regal understanding of physiology, but if I can't disseminate that in a way that anybody can understand, then nobody will want to be my friend, and nobody can benefit from hopefully the things that I've been able to learn along the way. So that's why I wrote a book, because I have a lot to say about this stuff, and I really, truly want to help people not have heart attacks, strokes, and dementia, and have a good understanding of what's true and what's not when it comes to cholesterol and when it comes to metabolic health.
Yeah, that's great, because there's so much misinformation and so much we get confused on what is this bad, is this good, and we call it good cholesterol, bad cholesterol. You know, a lot of people are talking about ApoA, ApoB, and you start going, what is all this? I mean, one's if this is normal and this isn't. So what do you like? What's the low hanging fruit for you? Like your book is the home security system in the lipid neighborhood. So like, give me a nutshell of that to understand, like, okay, who's the good guys in the neighborhood, who's the bad guys, who do you have to watch out for, you know, to keep your home safe.
For sure. For sure. And so what I say is, for everybody who does not want to have heart attacks, strokes, and down the line dementia, I want you to have a great home security system, and I want you to live in a safe lipid neighborhood. Your home security system has 4 basic pillars: normal blood sugar, normal blood pressure, keep inflammation low, and don't smoke or do drugs, because those are bad. But then your lipid neighborhood, that's your cholesterol panel, because every ApoB containing particle, and the vast majority of those are LDL particles, are potentially criminals that can infiltrate your arterial abode. And then the LP(a) particles, if you pick the wrong parents with that genetic lipoprotein, those are the felons, because per particle, they're about 6.5 times as likely to cause mischief in your artery wall if they end up there. But really, people don't live on paper. So we can measure your parameters of glucose metabolism. And when I say normal blood sugar, it's really normal insulin and blood sugar concurrently, because as chapter 1 of my book says, control your insulin, control your life is one of my mantras, okay? But nobody in 2025 ever says, my New Year's resolution is to be more insulin resistant. And, nobody wakes up and it's like, oh, it's Friday. Well, today's a good day to start smoking. These are axioms. No matter what your cholesterol panel looks like, you're going to have the normal blood sugars, normal blood pressure, keep inflammation low, don't smoke, all across the lifespan. But then with your cholesterol panel, it might look like you're living in a rough inner city neighborhood on paper, but people don't live there. So one of my catchphrases is, got plaque, get a CAC. What's a CAC? Coronary artery calcium score. It's the colonoscopy of the heart without the nasty pregame show. Because you lay down, low-dose CT says, hey, have you been broken into or not? Because calcified plaque in your coronaries is a late finding in the whole disease process. And so if you have been broken into, well, do you want to keep living in the same rough lipid neighborhood where you got broken into? Or, is it worth considering a conversation about how to move to a nice, safe, gated community with fewer lipid criminals all along the way, making sure that your home security system is in good shape? And so that's my basic framework for cardiovascular disease and what to think about there. And then there's a lot of things that we can go down to as far as dispelling the notions about good and bad cholesterol, and really defining the purpose of lipoproteins, because a lot of people like to think things are binary, like, oh, cholesterol is good or bad. And it's like, well, no, a lack of cholesterol is incompatible with life. But if a cholesterol-laden perpetrator ends up in the wrong place and kicking off the maladaptive immune response that results in atherosclerosis, well, that's not so much of a good thing. And so that's kind of it in a nutshell.
Yeah, that's so helpful, because a lot of us, like certain numbers, like one number, LDL, stands out and people go, oh my gosh, I'm going to die. And then you start looking at, like, what are your triglycerides, what are your HDL, what are your inflammatory markers? And I think we're in alignment with these things of saying, okay, if you have a chronic, it's kind of like the analogy we use with LDL. They go, is it good or bad? Is it, well, where's it going to grow up? What neighborhood are you in? Are you in the rough neighborhood where everyone's selling drugs and prostituting, or are you living with Ben Bickman in his Mormon house, right? It's going to make a difference of how you, most likely, maybe you don't. There's always a chance that you could get a bad kid that raised in a good, loving neighborhood. But, you say, what neighborhood are you putting that in? And so it's kind of the same analogy, like with a swimming pool. If you have a bunch of beach balls on top, and whether they're going to get oxidized and go down and clog your drain, if they're sitting on top, do you worry about them as much?
Yeah. And really the purpose of lipoproteins is not to, give you heart disease or something. And particularly the ApoB side of the family, the VLDL, IDL, LDL particles. Really they're mailmen, right? Most mailmen aren't bad dudes necessarily, as long as the mailman delivers the mail and then goes home at the end of the day. Where's home? The liver. And so, when you're shuttling out these VLDL, IDL, and, the LDL byproducts of these, they're not inherently bad. But, if that mailman, runs his trucking arterial wall, well, that's a bad mailman. And why would the mailman potentially go off down the wrong road? Well, if you've ever driven in a storm, that's difficult to know where you're going. And a sugar storm can really, really cause some problems. I lived the song Jesus Take the Wheel at one point when I got caught in a blizzard and flipped my car. Terrifying stuff. Well, if you're caught in a sugar storm, in the sense of diabetes and insulin resistance and things like that, well, this is why people who have diabetes and insulin resistance, you have such heightened risk of having cardiovascular disease, because the mailman should be delivering triglycerides primarily, a few phospholipids, a few fat-soluble vitamins to target tissues, which would be the adipocyte and the myocyte, and then going home at the end of the day. But what if your mailboxes are full? What if your cellular mailboxes are full? Is the mailman going to be able to deliver the mail? No. And what condition would cause those mailboxes to be full? Insulin resistance, they're jam-packed. They're wanting to deliver the mail, but they can't. So instead of delivering the mail, what are they doing? I don't know, driving around. And then, there's a traffic jam, and then also if you get caught in a sugar storm or something else, that's not a good thing. And so, anyway, just giving that framework there, as far as, hey, these guys aren't bad necessarily, but what could go wrong here? And if something has gone wrong, well, maybe we need to help clean up the mess a little bit.
Yeah, awesome. So you're talking about reducing your risk, right? And it sounds like these certain pillars you're talking about, high inflammation, never good in the long run, right? High sugars, high blood pressure, elevated blood pressure, and then smoking and drinking. It's kind of Ben Bickman's kind of saying the same things, exercise regularly, do whatever you can. So why do you think it is that like religion, like maybe controversial, but lipids are way more controversial? Like there's so much anger, and so in your view, where you're at, like you're going to see the Dave Feldmans come in, then you have the standard lipid guys. Like how do you bridge that gap?
Yeah, and I mean, the thing is, I think we can all agree on the pillars of the home security system, right? And that's why, hey, this is going to be a constant. Even the people who think that we need to have a, quote, physiologic LDL cholesterol level, and I'll explain why that's just not a very good argument, because you're born with an LDL cholesterol of like 22 to 44. And so people are like, oh, we should all have that, because that's what you're born with. Well, guess what? By age 2 months, your LDL cholesterol is 65 to 80, and your ApoB is 73. This is the Copenhagen baby heart study. So I don't think that's a great argument because you're born with a blood sugar of like, 35 as well. Or is that what we're targeting? So I don't think that's a good argument because the fetal liver is immature. But anyway, but for the people who, believe that, and who want to blitz everybody's LDL cholesterol down to zero no matter what. And then for the people who, think that LDL cholesterol, might be not the be all end all. Everybody's going to agree that, we don't want to be insulin resistant, and that we don't want to have high blood pressures, and that we are not better inflamed than non-inflamed. And, nobody ever says, today's a good day to start doing meth. Well, no, there's no day that's a good day. So we can all agree on those things and have, uniformity there. But I think a lot of it goes to what is the purpose of these things. And a lot of it is hamstrung by our didactic programs. I'm adjunct faculty at multiple medical programs, and all they get taught really, usually, and all we got taught is LDL bad, HDL good, everybody take a statin. And so that's what everybody kind of goes along with. And there's a lot more to the story. And so, like I said, LDL is not inherently bad. These are mailmen. And, if the mailmen go home at the end of the day, then, well, that's a good thing. But, if they end up in the wrong spot at the wrong time, that can be a bad thing. And then HDL good. Well, okay, HDL particles do a lot of good things. And so HDL has historically been called the good cholesterol, but really it's the same, 27 carbon cholesterol molecule. It's just a matter of what lipoprotein it's in and where it's going and what it's going to do. And so HDL is kind of like the police force. And so it is capable of doing some very charitable, magnanimous activities in the community. So HDL cholesterol particles can actually go into the arterial wall where there's been a cholesterol-laden perpetrator, and it can actually suck it out before it causes too much of a problem. That's called cholesterol efflux capacity. HDL particles are capable of doing that. That's really cool. HDL particles are even responsible for glucose uptake into skeletal muscle. That's a very little known fact. Well, that's awesome. Talk about a charitable community activity. I mean, nobody ever said, I wish I was worse at utilizing glucose. That's fantastic. So they can even have a role there. And HDL particles can even bind up lipopolysaccharide, or if it's gram-positive bacterium, lipoteichoic acid. And so in conditions where, there's sepsis or you're really sick, which is a bad day, those HDL particles can bind that up, bring it back to the liver in a process called reverse lipopolysaccharide transport, and then it can get excreted in the bile so you don't die. So, and HDL particles can do numerous things, and they have hundreds of proteins on them that dictate their functionality more or less. But really a static measure of HDL cholesterol gives you no idea of its functionality. You don't know if that police officer is a good cop or a bad cop or anything else, just by looking at what your HDL cholesterol is. And sometimes people with really high HDL cholesterol will have accelerated disease because they have a dysfunctional particle. I had one gal who had an HDL cholesterol of 108, and she's like, oh, I'm fine because my ratio is good, and whatnot. And she's telling me about her family history, and it's just riddled with all sorts of coronary events and ischemic events. And, we got a coronary artery calcium score on her, and, it was well over 1,000, and we had to intervene accordingly. So, you just don't know what the HDL cholesterol is doing. Conversely, though, we know low HDL cholesterol is associated with coronary events for sure. But why is that? It's a proxy for insulin resistance, because when you have chronically high triglycerides around the clock because your mailboxes are full, well, the HDL particles get fat and fluffy with excess triglycerides. It's like a police officer that's getting overweight and he's not going to be able to pass his fitness test. And so what happens is your body takes a couple of lipases, endothelial and hepatic lipase, and it tries to do a weight loss procedure on your bloated triglyceride-rich HDL particle, but it overshoots it, unfortunately. So in the process of trying to trim the fat, it leaves you a gaunt, emaciated HDL particle that's not good for anything. That's not going to pass his fitness test because he's too weak. And so it's like, darn it. And so what happens is it's actually your kidney that gets involved and catabolizes the ApoA1 particle. That's the primary constituent of the HDL. And then over time, you have low HDL cholesterol, as part of the metabolic syndrome, which is very much associated with clinical events. But it's not because of the functionality of the HDL particle per se, which it might very well be more dysfunctional, but it's really that low level that's telling you something more about the metabolic milieu. However, there are ethnic variances with HDL cholesterol. People who are of African ancestry, because of variants in steroyl-CoA desaturase 1 and LPL, they will have normal HDL cholesterol, normal triglycerides, but they'll be quite insulin resistant. So, generalizing it to everyone is not appropriate. But in general, when you see high triglycerides, low HDL cholesterol, well, insulin resistance, which there are many ways that we can identify insulin resistance. And I'm big on that, and so because insulin resistance, impaired fasting glucose, prediabetes, diabetes, it's like being almost pregnant. You are or you're not. It's just a matter of how far along you are in that disease process. It's all the same continuum. And hopefully we can identify insulin resistance in its infancy and abrogate that, similar to how we can identify coronary disease or any plaque in any vascular bed in its infancy and intervene accordingly there to shift the paradigm from reactionary to preventive when it comes to cardiovascular disease. And I think that anybody would be in agreement that, hey, we want to be preventive rather than reactionary, whether you're in the camp of let's blitz everybody down to physiologic ApoB levels, or whether you're in the camp of, everybody's, wants to identify disease, and so we want to use our tools like coronary artery calcium scores and CT angiography and things like that, because no one out there wants to have clinical events. It's just a matter of how we get there together that hopefully we can do that.
I was curious, just stepping back for a second, that patient that you said that had the high HDL, that had a lot of coronary disease, were her triglycerides and LDL, were they all out of whack and insulin resistant, those kind of things? Or was that just an isolated?
Yeah, and so there's some interesting, and this is not super common. There are some variants in something called SRB1, and that can result in high HDL cholesterol and accelerated disease because you have dysfunctional particles, even in the absence of insulin resistance. There are some other variants in endothelial lipase and hepatic lipase that can also cause high HDL cholesterol and accelerated disease. But then there are variants in like CETP, cholesterol ester transfer protein, that will result in high HDL cholesterol and really no marked disease. And so it's interesting, but the HDL is very complicated. And so it's like, you just don't know what it's doing. And so if somebody has a good, let's say ratio, well, that's good. If your trigs are low, good for you. You're probably not insulin resistant depending on the ethnicity. But, is that going to stop me from ordering a coronary artery calcium score? Got plaque, get a CAC. Well, you don't know. And so I like to treat it as the colonoscopy of the heart, and just get it as part of the, identification if you've been broken into or not. And if you fire up a score of 0, hey, let's check back in 3 to 5 years, depending on your risk factors, and carry on, focus on your home security system. Like a colonoscopy, if you have a polyp, you don't say, well, you've got a villus adenoma here. Let's just wait around, for you to get colon cancer. Then we'll consider doing something about it. I mean, you take it out and then you check back regular intervals. Well, if somebody has had signs of a break-in, okay, well, do we just wait around for you to maybe have a clinical event, given that 2/3 of myocardial infarctions are in a non-obstructed vessel, from ICONIC is one study and other studies as well. Well, I would say probably not. Let's do something to hopefully, stabilize whatever plaque you have and then potentially even regress that plaque burden so that, we're not going to have some sort of life-changing, game-changing, terrible thing happen to you.
Yeah, I think that's really important to look. And so, I would love to pick your brain a little bit on this, since you're a track athlete also, which is the worst sport ever, because every other sport, they say, if you don't listen, we're going to make you go run. So no one wants to run. But you chose that sport. But, I'm seeing data, and I've heard a lot of talk. Mark Sisson and I talked about it, and a few other people with these high level athletes are having a high coronary calcium scores. And
Yeah.
there's arguments saying because you have increased, it doesn't necessarily translate over increased cardiac risk.
Yeah, that's one of the things that one of the unanswered questions that I want to have studied. And so it's good because it's usually extreme endurance athletes that have this excessive coronary calcification, and that's an interesting thing. And so at one point it was thought that okay, they just have high calcified plaque burden, but they don't have any of the fibrofatty plaque or the low attenuation plaque or some of the high risk plaque features that are associated with actually having clinical events. There was one study that actually showed that they had a lot of mixed plaque as well. And so the plaque with these athletes wasn't necessarily as inert as once thought. Now, I'd like to look at the LP(a) levels in these people and see if there was something else contributing there, because you can have a perfect home security system and still get broken into if you pick the wrong parents with LP(a). And I have a really good story of one of my friends who I'll have to tell you about with LP(a), who had no risk factors except that. But anyway, so, I'd like to break that.
Is there anything we could do about LP(a)? That's more genetic, right, in nature?
Yeah. I believe there is. I believe there's ways to operate with nuance, even though we don't currently have a drug approved for LP(a) lowering and reducing cardiovascular events. The only FDA approved indication right now for those with high LP(a) and established disease is lipoprotein apheresis. And so, which is basically dialysis of your lipoproteins. And Patrick Moriarty over in Kansas City has done some great work and helped a lot of people out with his cohort there, people. But there are therapies on the horizon specifically for LP(a) that we'll see. Those hopefully will have a readout in the next few years, and we'll see if lowering it actually translates into reducing clinical events. I think it will, but this is why you run the trials.
But right now, it's not like you could change your diet and make a change. Like, I'm going to go vegan, or I'm going to do something.
Yeah.
Other than decreasing your overall risk by decreasing inflammation and high insulin resistance.
Yeah, and it's primarily genetically determined. And so, but when people go on a low carb ketogenic diet, some people will get maybe a 15-20% reduction in LP(a). Is that enough to make a difference? We're not sure, and so but anyway, so that's an interesting thing. LP(a) right now. There is actually some interesting data from the Women's Health Study, from the Esprit trial, and also from MESA that, in primary prevention, when people have high LP(a), baby aspirin in a low bleeding risk individual, might be worth trying. And so the Women's Health Study and Esprit, they did the genotyping of people with high LP(a), and there's this one SNP in LP(a) called the RS3798220 SNP. And those people had a lot of benefit from baby aspirin. But are we going to go around genotyping everybody's LPA isoforms? Well, probably not, but it is interesting. And also, when we look at the data and we look at mechanistically what various lipid lowering therapies do to LP(a), I think it helps us operate with some nuance. For instance, statins, they increase LP(a) on average 19.3%, some more, some less. Okay, that's interesting. And so does this, is it a good idea just to blitz everybody with King Kong atorvastatin 80, even if they have a high LP(a)? Well, I don't think that's in general a great idea, anyway. But, you're just going to get a dose dependent increase in the felons to the lipid neighborhood as you're trying to address, some of your run of the mill potential criminals. And so I think it warrants a discussion of combo therapy in people with high lipoprotein(a) if you have a good reason to get living in a safer lipid neighborhood, if there's been evidence of disease or anything else. And while I'm here, my friend, so he's a guy I run with. He wasn't extreme endurance athlete. He's a good athlete, but his one risk factor was LP(a). And he has this bad family history. And so his LP(a), I was like, dude, you got to get your LP(a) checked and get a CAC. And his 10-year risk calculator, which I think those are garbage in general, was 2.3%. And so he wasn't even insulin resistant by my standards, and this is with advanced lipid panels, using NMR spectroscopy to identify some of the fractionations that would suggest insulin resistance and all of those things. His HSCRP was 0.4, no high blood pressure, had decided to not do drugs, which is great. And so he gets his LP(a) was 128 mgs per deciliter. And anything over 50 is about 80th percentile. So 128 is quite high. If you're using milligrams per deciliter to measure it. His CAC was 2,814. And so, for reference, a CAC of 300, you have equivalent risk of having an MI as people who have had prior events, even over 4 years from the confirmed registry. And so 2,814 is like, wow, how are you still here? And so he had so much extensive disease that he had to have a 5-vessel CABG, coronary artery bypass graft, a year ago. And then just last weekend, he did a half Ironman.
I saw your post.
triathlon,
Yeah, I saw your post.
And he qualified for Worlds in France. I mean, he didn't just finish it. It's not like these people that, they say they ran a marathon and it took them 9 hours. No, you strolled. No, he went and crushed it and finished in 5.5 hours. The course was actually long. They actually mismeasured it. And so anyway, but that's inspirational is overused, the word, and that is truly inspirational. So anyway, I'm a big fan of, obviously getting CACs and, checking for Lp(a), just because, it can be a bad guy. But I know I went off the rails there, but back to the athletes, right? The athletes paradox, as far as, people who are extreme endurance athletes who have this excessive calcification, does that mean they're at higher risk of coronary events? That we haven't really looked at that. We don't have enough hard data to say one way or the other. However, they've got extensive disease. And so why does that happen? That's an interesting thing too. And I think that whenever you're putting your body through any sort of stressor, the goal is to adapt to the stressor in a beneficial way. You got to break down to build up, and so, however, I think there comes a point where, because you are just pulling the lever so hard and burning it too hot for too long, that your body cannot make a beneficial adaptation to that imposed stressor. And the amount of volume that these extreme endurance guys are doing is insane. I used to run 100 miles a week when I was running, for Idaho State, and that's pretty extreme. That's pretty ridiculous. But these guys are doing that for decades, and they're doing, multiple training modalities, and they're just burning it so hot all the time.
And they have an increased risk of atrial fibrillation too, right? We're seeing that more in these long,
big time. The AFib is unequivocal. The actual, ischemic events is in the air. The atrial fibrillation, it's not even close as far as your hazard rate, as far as that. And I actually had an episode of AFib myself, which was terrifying, and it was pretty bad. But anyway, so, it kind of messes up your pacemaker a little bit. But so that's I think unequivocal. As far as the relationship between heart events, I think that's still in doubt. But what's interesting to me is, why does this happen mechanistically? No one really particularly knows. I think in general, the not being able to make a beneficial adaptation to the stressor is something to it. But what's interesting is the role of parathyroid hormone in that whole process. Whenever you are doing a lot of endurance exercise, there comes a point where PTH levels go up quite a bit. And PTH, is the master regulator of calcium homeostasis in your body. And so potentially it's dysregulating the balance between calcium and phosphate there, and potentially that calcium is getting in the wrong places there. That's one theory. There's probably something to, chronic cortisol elevations that continue to rise and don't come as well when you're doing those sorts of activities. And there's probably some other endocrine disturbances that happen.
You would think like nitric oxide, maybe you can't sustain it for that long. Maybe it's like for this a certain time you can't produce it, because a lot of times they say when you exercise, you're increasing your nitric oxide to protect the vessels, even though your blood pressure and heart rate and everything's going up.
Yeah. And I also think too, when these guys are doing these crazy long events, they have to eat, they have to fuel while competing, which is really hard. I think that's a huge challenge, because and you're in sympathetic overdrive. Whenever you're exercising, your sympathetic nervous system is turned on. But then it's like, okay, now I'm actually having to ingest something while I'm in sympathetic mode, and then you're and so I think your body kind of gets confused, and it's like, what the heck what is this? And I think
you can't digest as well either.
And also, I think that there's this is one of the most complicated topics in all of lipidology is something called the ANGPTL family of proteins. And so there's these ANGPTL 3, 4, and 8, and they're regulators of lipoprotein lipase, and they're regulators of fuel partitioning when it comes to, okay, I want to funnel fatty acids toward oxidative tissues, or I want to funnel fatty acids towards storage. And I think that potentially too, there is something that is dysregulated there, because, okay, generally when you're exercising, we'll want to fuel oxidative tissues, but then it's like, okay, now I'm introducing caloric stimulus, and generally I'm going to be in storage mode, and it's like, wait, what the heck's going on? So I maybe there's something to that as well, but I really do want to. And then there's this recent article actually. There was something called imidazole propionate, and this was from.
I was going to bring that up. Yeah,
so
it's amazing. That's crazy.
Yeah, and so that's a risk factor for having premature atherosclerosis, and that wasn't on my bingo card. I mean, it's like, whoa, what is this? And this,
me either. Maybe we could talk about that a little bit, because one of my focuses lately, you may be interested in this, because a lot of the carnivores and people who are like super athletes are like, it's a badge of honor. Like, my LDL is 500, I'm happy. It's like, I don't think I'd be that happy based on what we're seeing. And so what's interesting, in my practice, I've had 6 patients who are strict carnivore for 2 years or more, and they have major leaky gut, major inflammation, C. diff, colitis with minimal antibiotic usage. The gut diversity is so, and all these guys, when I looked at that IMP that you're talking about, all the guys who like acromancy, all these guys who digest that in the gut and you get rid of it, when they go down, you absorb more of that. And you go, maybe this dysbiosis, maybe just adding a little fiber to your diet is going to make a benefit so I'll show you a number here, a couple of numbers. Maybe I can just show you, because it was wild when I saw it, but it was a consistent finding when I look at their GI map and their LDL. So if someone has like C. diff, colitis or really bad gut dysbiosis, like one of my guys' LDL was 229. Carnivore for 2 years. We didn't change his diet one iota. We didn't change it at all. All we did was say, let's try to fix the gut lining a little bit. We'll add in a good probiotic and some inulin. His LDL went from 229 to 98. And his his inflammatory markers came down dramatically. Everything got better. I was like, wow, we didn't change anything. And his insulin went from 17 to 6. And his A1C went from 5.6 to 5.1. And you go, this guy's getting so these and I was intrigued when you said the HDL plays a role in getting rid of lipopolysaccharides, which we know is causing atherosclerosis. You go, wow, maybe we need to look at that,
Yeah, that's intriguing. That's really compelling. Those stories you're sharing, you should look into getting that, writing that up, because I think that's kind of one of the things that's hard to know what to do with right now, as far as we know. I mean, the gut is so critical for many things, but it's like, what do we do about it? And so, and with imidazole propionate, if this becomes a good biomarker, the first low-hanging fruit that was suggested was, it's a metabolite of histidine, right? So just decrease dietary histidine. That's not the answer.
It doesn't make a difference. Yeah.
No, dietary
Nick,
histidine,
I don't know if you saw Nick Norwich was talking about this. I was like, wow, I've never heard of this before. This is pretty wild, right?
Oh, I didn't hear, and Nick's a smart guy. I'd love to chat with him sometime. But I didn't hear what he was saying, but just dietary histidine actually is associated with improved parameters of glucose metabolism in multiple studies. So, which flies in the face of imidazole propionate being associated with diabetes and atherosclerosis. And so, I think it's interesting. A lot of times it's the fate of the whatever metabolite it is that matters a lot more than just the metabolite itself. Same thing with glucose, right? I mean, glucose, if you're training for the Tour de France and you're utilizing glucose, and it's going into your mitochondria and propelling oxidative phosphorylation, well, that's great. But, if you're not utilizing the glucose efficiently, then we're going to run into all sorts of advanced glycation end products and all sorts of problems. And so it's the fate of a lot of these things that we're putting into our system that matters a lot more than just the individual constituent itself.
Yeah. So you can see this guy. LDL 227 to 99, insulin came. This is 2 years carnivore. I'm like, how can you? So I go, either you're cheating and you're eating and drinking and you're stressed all the time, because how does his, and it dropped down, and look at his HSCRP went from 4.5. Now that's given he had C. diff. This lady too also had C. diff, right? So, but the point is, they're young, healthy people getting C. diff on minimal, like two pills of amoxicillin. Like, it's crazy stuff. But one of the guys, we go, look, I'll just show you his, I don't know if you ever look at these GI maps, but all of his microbiome that maintains the gut lining was like negligent, like totally missing. And William Davis mentioned this first. He goes, I'm worried about acromancy. If you starve it of sugar or starch too long, it'll start eating the mucus layer. So this is the same guy 6 months apart. And look at all of his acromancy went to upper normal. And he has seizure disorder, totally went away. His A1C dropped from 6.4 to 5.3 or something crazy. And he goes, oh my gosh, I feel great. My mental focus, everything got better. I was like, we didn't change his diet. So it's not necessarily
That,
the carnivore. It's more that he probably had gut dysbiosis that led him to go
yeah.
carnivore to catch out the processed foods, right? But you know,
Wow,
this
that's phenomenal.
it's really
And
interesting, huh? I mean, when you see that, you
was
go,
it the
huh?
same? Was it the same pro? And you know, I'm really curious about this too, because was it the same probiotic that you were deploying in both of these situations?
I did, yeah. He took a Acrobancia supplement because it was so low. He goes, I'm just going to take it. He took
Yeah,
seed probiotic. I have no financial interest in those guys, and inulin, which is it's a prebiotic that helps feed
yeah,
the Acrobancia and these good micro. Because I'm like, if you starve these guys too much, it may be an issue. Maybe William
yeah.
Davis is right. You know, he wrote Wheat Belly and he wrote another book called Super Gut. And so I was like, man, I wonder if he's right. So I'm actually interviewing him, I think, next week because I go, I want you to see this data because you called it. He called. He goes, I don't have data, but I suspect this is what's going to happen. And so it's not a popular message, but you know, these guys all got better. All their markers got better. All they did is add in a little fiber because they had like you have zero. And the argument always is,
Yeah.
okay, you don't need fiber because you know fiber is just going to clog the pipe. And I was like, well, once you're missing that mucus layer, if you go on a water slide with no water, do you think you're going to slide very well?
Yeah, that's not fun.
So
So
this INP goes up and all these things that you're talking about is like, wow.
mhm,
And I didn't
mhm.
realize till you said that HDL actually is going and scavenging
Oh
the
yeah.
lipopolysaccharide, which is
Yep.
massively bad.
Yeah, and I mean, and that would make sense, right? So a lot of times when people get some sort of infection, who are the people that end up dying? I mean, they have the low HDL cholesterol, you know, and you know when we went through, you know, COVID and stuff, the types of people, unfortunately, who you know succumbed to the first variant there were typically metabolic syndrome type
Mhm.
people and people with low
Diabetics.
HDL cholesterol, and yeah, who weren't able to, you know, appropriately mount that defense. And so you know, HDL it does so many good things, but we just don't know looking at a static measurement, you know, what it's doing or not doing. Just more of a proxy. If you're going to use HDL cholesterol for anything, it's like the hemoglobin A1C of how high your triglycerides get after you eat in general. But there's always exceptions, and there's too many exceptions to just be dogmatic about, oh, your HDL cholesterol is this or whatever. I feel like I can make a pretty good inference, especially if I have my, you know, NMR spectroscopies of advanced lipid panels, which I really love, especially in primary prevention, just because we can really identify insulin resistance even earlier than we can even see. Even people can even have normal fasting insulin, normal HOMA-IR, and you can have, you know, small dense LDL particle elevations, large VLDL particles, and
I
you
was
can
going to
identify.
ask you about that. I've seen that.
Yeah.
I've racked my brain about that. They have
Mhm.
pattern B and their
Yep.
insulin's 2 and
Mhm.
everything else looks good. So I'm wondering, gosh, now that I'm in retrospect, I'm like, could they have, you know, something like a lipopolysaccharide, something leaking across that's giving them issues?
Yeah, you know what's interesting? I have a really good, and this is in my book too. And so my wife was actually a great example of this. And you know, my wife is beautiful, gorgeous, all the amazing adjectives. She's my best friend and amazing in so many ways. And she's half Sicilian, half Puerto Rican, so she's she's an Italo-Rican goddess basically.
Yeah.
So anyway, but she wasn't exercising at the time, and she was feeling kind of, you know, not amazing. And so I'm like, okay, well, let's get some blood work because blood work is fun. And so her fasting insulin was like, you know, 4, you know, her fasting glucose was 78, nothing crazy there. But her LDL and her LDL cholesterol was like 80, but her LDL particles were around 1300. So she had discordantly high LDL particles for her given mass of LDL cholesterol, and her small dense LDL particles were elevated. And so that's an early sign of insulin resistance. And from Jerry Schulman's work at Yale, you know, insulin resistance most times starts in skeletal muscle, and she wasn't exercising. So I'm like, okay, well, let's
Mm-hmm.
start exercising. And we'll recheck in 3 months. And she wasn't doing anything like crazy monastic or Spartan or even, you know, what I do. And so she was just 2 to 3 times a week would go and do a combination of resistance exercise and aerobic exercise, you know, just put in the work and, you know, get out. And she didn't even really change her diet. And her diet is, you know, not exactly pristine, you know, way too many dino chicken nuggets for my taste. But anyway, so she didn't even really change her diet at the time. And we rechecked her lipid markers in 3 months, and her LDL cholesterol didn't budge, but her LDL particles went from 1300 to 994, and then her small dense LDL particles, which had been elevated, completely normalized. And so that those early signs of insulin resistance, which
Wow.
typically starts in skeletal muscle, well, guess what? How do we abrogate insulin resistance skeletal muscle? We move the muscle, you know, and then, you know, we're able to, you know, rectify things. And so even though nothing else really changed, and even though her fasting insulin was normal and our other metrics that we would typically use, to identify insulin resistance were fine. She was showing early signs there, and we were able to detect that using the advanced lipid panels. And that's where I think the greatest utility is of the advanced lipid panels, whether you do ion mobility or NMR spectroscopy, is, markers of insulin resistance that you wouldn't otherwise detect. And, you could get an oral glucose tolerance test, right? But that stuff's nasty. And depending on what dietary pattern you're endorsing, there can be some things that you have to consider there. And so I really like the advanced lipid panels for the true primary prevention person, because you can really, get down and dirty with the appropriate lifestyle intervention based on what you see there.
Awesome stuff, man. I'm so glad, because this is educational for me, because I see some things you go, why am I seeing this? Is kind of odd, And so, and I've seen people also flip, like they have a super high LDL, they go on a statin and they flip from pattern A to pattern B. And I'm like, they have more small dense LDL.
And okay, so statins, they do some real good things, right? But the thing about statins is people will poo-poo the nuance of diabetes and the insulin resistance that comes with statins. It's a real effect. And so there's a meta-analysis of over 120,000 patients treated with statins. And moderate intensity statin, you have a nuance of diabetes risk over 5 years or so of 10%. But with high intensity statin, it increases to 36%. Whoa, that's not trivial.
Wow.
And then additionally, mechanistically, there is an intermediate in the 37-step cholesterol synthetic pathway called geranyl pyrophosphate. And geranyl pyrophosphate, or GGPP, ends up resulting in GLUT4 translocation to the cell surface of the adipocyte and myocyte. And so statins decrease GGPP because they're decreasing cholesterol synthesis. And so if you're getting a decrease in GGPP, you're getting a decrease in GLUT4 translocation. Well, what's going to happen? You're going to get less glucose uptake into your insulin-dependent cells, and so in your tissues. And so, it makes sense that we're seeing insulin resistance and also, dysglycemia, especially at the higher intensities of statin doses. And so for me, I'm a big combophilic fan. If I have a reason, let's say I've identified, you have got plaque, get a CAC. Oh, you have a positive CAC. And I want to get you living in a safer lipid neighborhood. Well, am I going to just go and blitz you with a torvastatin 80? No. If I'm going to use a statin, I'm going to use it at the lowest dose where I get the most LDL cholesterol lowering, because every subsequent doubling, you don't get that much more LDL cholesterol lowering, maybe 6%, and then you increase the side effects a ton. I don't want that. So I'm going to use it in combination with something like ezetimibe. And it works very well mechanistically together, because whenever you decrease cholesterol synthesis with a statin, your body's smart. And it increases absorption, not just from the gut, but from the hepatobiliary interface where Niemann pick C1 like 1 is expressed. And so if I can do that, okay, I'm going to get better lowering. I'm going to not worsen, your insulin resistance to the same degree. You're probably going to tolerate it better and not run into some of the myopathic symptoms, which is also a real effect. And then, hey, hopefully we got you living in a safer lipid neighborhood. If you have any plaque, hopefully we can confer some stability and maybe even lead to some plaque regression. And I think that would be appropriate. And additionally, with statins, they, increase PCSK9 levels. Atorvastatin 80 increases PCSK9 by 46%. Well, PCSK9 is putting your claw grabbers out of commission. If we were trying to win the APO bear, at the arcade for our kids, and the LDL receptors like that claw grabber. But if PCSK9 comes along, it puts it out of commission. That's no good. And so your body's fighting you. So anytime that you're trying to manipulate your lipid neighborhood, if there's a reason to pharmacologically, your body fights you. And so it's like, well, let's just, touch on multiple pathways to achieve the desired effect without ruining your home security system. Because for me, insulin resistance and not being insulin resistant is such a huge priority. And if I'm, using something that's just going to, maybe get you living in a safer lipid neighborhood, but it comes at the expense of your insulin sensitivity, I don't love that. And so I'm going to try to play the game a different way because I very, very much value my mantra, control your insulin, control your life.
Yeah, those are all huge. And that's the other with the PCSK9, like you look at the overall mortality data, you're like, am I going to live any longer? I mean, it depends on the situation, obviously. But the other question is, in this community, a lot of people are like, never do a statin drug. And then you go, there's a nuance to that, right? If you're diabetic, if you have super high coronary calcium scores. And so in your perspective from what you're dealing, because you deal with, this is what you do all the time. Someone comes in with a 2000 coronary calcium score. do you have a like saying, is there a benefit to like there's discussions about reversing plaques, not reversing plaques? Does it make a difference? Does it make the plaques more unstable if you're doing K2 and D3, for instance, or nattokinase? Do you have any feelings anywhere on there where you feel comfortable?
So, and this is a great discussion. So when people are getting like stratospheric CAC scores, I mean, I would hope that we're also, working with cardiology to identify if there's any obstructive disease there, and when it starts getting that high, like my buddy, 2,814, he had 5 vessels that were like 90% occluded. So, and he has a shirt that says stents are for sissies because he had.
And did they stress him? Did they stress him first and see ischemia, and then they went to the.
No, he didn't do a stress test because stress tests are interesting too, because you can beat a stress test, especially if you're fit. And the guy was still running.
Yeah, that's what I was thinking.
Yeah, so I'm not a huge fan. And President Clinton is one of the classic examples of a guy who passed a stress test every year and then ended up having to have a bypass himself. And so stress tests I think are fine to run and good, but not the be all end all. You can't really fake the imaging tests, especially with how good CT angiography is now. So anyway,
it's funny you said that too, because George Bush Jr., he rode his mountain bike through the mountain. He did all this crazy ride. Then the next day goes and fails his stress test, and they stented him right away. And they're like, he was asymptomatic with maximal exertion.
Yeah, and so So, I mean, but some guys will cath anything that walks. I mean, they would just look. I mean, these are probably the same types of guys that enjoyed doing prostate exams in school or something. But anyway, So there's some nuance to this, but. As far as plaque, let's say you have plaque, right? We probably want that plaque stable, especially given that 2/3 of myocardial infarctions happen in a non-obstructed vessel, and it's vulnerable plaque, and then it breaks off, and then you're 100% occluded, and we're having a real bad day. So I think conferring plaque stability is good, and we believe that the statins are conferring plaque stability by increasing the calcific content. Because they increase, if you start a statin and you've got a baseline CAC, your CAC is going to increase, but, we don't think that that's causing problems. It's just conferring stability.
Well, and that's the other thing is like one of my patients went to his cardiologist. He's been on a statin drug for 22 years and his I'm like, what did the CACs do? The CAC was high, but pass the stress test, pass all the other subsequent tests. You're like, why'd you even get the CAC? I mean, do you see a reason with someone who has a stent already, or they've been on a statin for 20, 30 years to get a CAC?
If you've already been in the cath lab, no, but for just somebody who's been on a statin for a while, right? Because sometimes people are just thrown on a statin for no reason and it's like, why are you on this? And they have a CAC of 0.
Sometimes.
It's like, I mean, look at this. The number needed to treat for someone with a CAC of 0, asymptomatic person, CAC of 0 for a statin is 3,571 to infinity, right? So, are we really, using this appropriately in that situation? Well, you tell me. But, for the person who has been on a statin for a long time, right? Do you get a CAC? I still think there is some utility, and here's why. So, for people who have really elevated calcium scores, like in the range of 300, 400, even if they're on a statin, they have a real big increased risk of having coronary events, even if they're on a statin. And so I think that would warrant a discussion. Let's say someone's been on a statin for 10 years or whatever, they get a CAC, it's 600. I'm gonna be really have a good discussion with that person about intensifying their lipid lowering therapy, because even though they're on a statin, their hazard rate is attenuated. It's still at least 2-fold higher than somebody who has a lower calcium score. And so I think that there is still some utility. It's controversial as far as serial coronary artery calcium scores, but there is some data that the rapid progressors, either, greater than 15% annually if they already have a CAC of 30 or above, or when they use the squirt, that's the square root transformed methodology to assess plaque progression. People who are rapid progressors, they're at high risk of events, even if they're on a statin. And so I think that there are certain situations where you can, consider repeating a CAC score. A lot of these folks who are really on it, or who are in the preventive game, they will have access to some of the real, fancy bells and whistles, like some sort of CT angio with AI. That can, give you the low attenuation plaque and some of the higher risk features. Fat attenuation index is another interesting marker. And so some of these other things that can help you hopefully individualize your regimen for them when it comes to both, whatever metabolically is contributing to some of these high risk features, and also from a lipid perspective.
Are there any supplements you would recommend in these kind of people, like K2D3, nattokinase, any of those? Do you see any benefit to any of these kind of, there's a lot of talk about people reversing plaques.
Yeah, nattokinase is interesting. And so there was that, and it seemed to be real high doses. So, it was like over like 10,000 of whatever they were using that seemed to, with carotid, and it was looking at carotids. And so that's an interesting study. I think the jury's still out, on those things. D3K2 is interesting too, because statins do decrease, K2, matrix GLA protein, which is a vitamin K dependent enzyme. And so, but is that actually helping? Because, statins are increasing calcification, but we think that that's a good thing. And if we're throwing on some, K2 or what are we doing in the vascular? Well, I don't really know. I don't think, and so I think it's, hopefully we can study that a little bit more. I'm not real bullish on most supplements. Personally, creatine, take some creatine. And creatine is a good thing too for statin associated muscle symptoms, because statins actually decrease creatine synthesis. So the committed enzymatic step in creatine synthesis is something called guanidino acetate methyltransferase, and statins actually decrease that. And so, and there's a couple small studies where they used creatine in people who had statin-associated myopathy, and they had a greater than 50% improvement in their myopathic symptoms just with creatine. And creatine is pretty low-hanging fruit, and there's some pretty compelling data coming out for neurodegeneration too.
Dementia, Alzheimer's disease and Parkinson's.
And it's just providing more, substrate for your phosphocreatine reaction, which is a great way to synthesize ATP quickly. So I think it's one of those virtually no risk, high reward sort of things for many reasons. And I personally, I take magnesium as well, but like, a lot of the supplements are like some mystery meat cocktail of proprietary blend shrubberies that they found off to the side of the road. And I'm not, I don't know. I'm not a huge fan of most of what goes on there. But I also acknowledge that, hey, there might be things that as we study, like D3K2 is interesting, right? And studying I think nattokinase is really worth studying more. Some of those things might make me more compelled to reach for those if we can have a better understanding of the right person at the right time in which to use those. We have pretty strong data just from the plaque discussion as far as plaque stabilization and regression with some of our available tools in our pharmacologic toolbox. And so, I think that there's some good stuff there that we have that we know a little bit more about than the supplement world at this point.
Yeah, awesome stuff, man. You were supposed to do a rap for me, is that right?
Oh, if there's, what's funny is when I go to like the National Lipid Association conferences or some of our national conferences, I will usually, rap about something, or make some parody of some pop song. Actually, I think you might have been on with Austin Dudzinski he's a really good friend of mine. Hopefully he can make a guitar version of the song I wrote called "Taking the Mount Jaro." And so there's this musical called Dear Evan Hansen. I don't know if you've seen it. But my wife and I went to this musical and we're like, that wasn't that great. But there's a song called Waving Through a Window, and it's super catchy. And we're like, man, that song is fire, and I'm like, waving through a window, and I'm like, taking the Mount Jaro. So I rewrote the whole thing to just be talking about somebody's, reaching the zenith of metabolic health after failing like Contrave and everything else. But anyway, so I have fun with stuff. And then, so anyway, if the people want a sample, I could give you a little bit of one of the raps if you want. So, but
you got it, man.
Up to you, man.
You could do a little sample for us.
Okay. We'll give it.
I'm not going to help you out. I'm not doing background or anything.
And so, might as well, right? This is probably the first person somebody's ever done, a little bit of rapping on this.
Pretty positive of that. Yeah.
So I did another parody of a Nelly song, like circa 2004 or so. This Ride With Me, or With Me. Yeah, we don't say with, we say with.
Yeah,
Like,
Whitney. Yeah,
we're
totally.
we're with the boys. But anyway, so I redid this one. So it's, if they're running high on their ApoB and the family's all got a CVD and they've got high lipo, hey, but no diabetes, but they're still worried about myopathy and how statins will screw up your A1C. So check out this book today, hey, and get them a copy. And usually I have a copy of my book here, because it's like, hey, anything you wanted to know about all this stuff, it's in here, and you can be assured that you're making the right decisions for yourself, even if you pick the wrong parents with some of these factors. So anyway,
Yeah, awesome stuff, man. That's
so there you go.
so cool. So tell me, let's switch gears here for a minute. A youth pastor, so you're a scientific guy. Clearly, like anyone listening is going, "This is a scientific guy," but you're a man of faith too. And you go, how do you rectify those things? Because I get asked that question all the time. I'm a person of faith, and they go, "Brian, how can you believe all that hocus pocus stuff and trust science?"
Yeah. So just trusting the science. I mean, we saw how that went for us, But anyway,
yeah.
yeah. So and science itself, I mean, that's a reification fallacy to say that trust science. I mean, because science itself is a set of tools that we can use to better better understand the world in that we live in. So basically, I believe that everything that we've been talking about today, and all the things that I've had the privilege of learning, is just a testament to the creator. Because when you look at the complexity of everything and all these things that we've been talking about, I mean, lipids are so crazy complicated, and to think that, oh, okay, well, yeah, all this is just some sort of accidental process, and, somehow there was nothing, and then I don't know how, but nothing exploded, and then we have all this amazing order that we see in these systems. I think that's a big stretch. And whatever you believe about the origin of the universe is not a scientific discussion. It's it's a historical one. No one was there, and so it's like, all right, well, what do you believe about that? Well, I believe that there is a sovereign being who created it all, and then and then everything from there proceeds in a way where I don't have to contradict myself from there. But everything requires faith. Just turning on your faucet, and drinking from whatever and maybe you filter your water, maybe you don't, but you have faith that what you're putting in your system isn't going to kill you. So life is lived with little steps of faith.
When you go through a red, when you go through a green light, you hope the other guy has a red light, right? You just believe that's gonna. You don't check it. You just go, yeah, it's gonna be red if it's green for me. It's gotta be.
And the end of my the end of my book, and there was a couple people who haven't. There was one guy who didn't like my book because he didn't like the conclusion. But I really think that the conclusion of my book is I think a beautiful metaphor of of metabolic health and spiritual health, and how those things go together. I'm not going to spoil it too much for people, but I just feel incredibly blessed. I feel like, God has given me a lot of really cool opportunities, and I believe that God gave us bodies to keep moving, and he gave us minds to keep learning. And I think both of those things are so fun. And for as long as he keeps me around, I want to, try to be crushing it. And I want to be trying to help people add life to their years in the process. And so that's where I'm at.
Yeah, it's awesome stuff, man. That's awesome stuff. And that's so true. And like, you start thinking about it, it's like, I always had to think about, like, why did we get fat? Oh, because you don't get fat, you get diabetes. Oh, why do we have high LDL cholesterol? Why does your body make something to kill you? Is my body ever trying to kill me? No, it's like, it's in a bad environment because of choices we make a lot of times, right? Or we just chose bad genes or bad parents, like you say. Sometimes we got a bad cards dealt. So you want to make your hand, you play your hand. Even if you have a terrible hand, you bluff through. You try to do it.
Pretty much.
Right? You play the hand you got dealt, and sometimes some of us didn't get as good of a hand as other people did, and it's going to be harder work, and you got to figure it out. But man, your work is so awesome, and I love that. That you have the open mind to go, okay, let me think about this. Why is this happening? Why are we seeing these things? And making this super, people listening is super complex. But then you go, okay, here's some low hanging fruit you could do. Like, keep your inflammation down. Here's the big pattern, and then we try to fix the other stuff that we can, or take pharmaceuticals to fix if we have to, or change our diet, or exercise more, whatever.
Yeah, People get annoyed because I'm like, well, here's the answer. All these things are it's so beautiful how complicated all these things are. And I love biochemistry more than anybody, right? But it's like the answer at the end of the day is sleep, don't eat crap, move, lather, rinse, repeat. And it's like, oh man, come on. Well, that's it. And then, understanding how our various tools we have in the toolbox work and how we can apply them in the right situation, just to help people add some life to their years is always a good thing. But whatever the question is, when exercise is the answer, I feel pretty good about that.
Yeah. And community and loving people. And, we talk about the Mediterranean diet. It's a Mediterranean lifestyle too. There's not just what they're eating. They're chilling. They go, I'm not working today. It's too windy. Let's go hang out.
There is an unquantifiable benefit to just not caring about the dumb stuff, not majoring on the minor. When people are able to go through and just have fun with stuff and you're just like, hey, this is good. I'm blessed. Every day is a gift and I can wake up and, hopefully take advantage of those opportunities I've been given. Man, that's cool. And like you said, so the Mediterranean lifestyle, but then Copenhagen, right? The Copenhagen heart study. What are the sports associated with increased longevity? It's the racket sports. And even golf is up there, right? So things that you're doing socially, things that you're doing together, is there's unquantifiable benefit in just having fellowship and having community.
Awesome stuff, man. That's what we're trying to build here. We're glad to have you as part of it. Thank you for and when you get new stuff, when you come out with your new rap, your new books, whatever you're doing, you have an open invite, and yeah, I'd love to get you over to Life's Best Medicine, talk more about faith and life and all these other factors that influence life. So if you're having a miserable life, who wants to live longer?
For sure, man. There's a big difference between living and existing, right? And that's why I would love it to come back at some point and talk about cholesterol in the brain and my kind of framework for neurodegenerative disease, because that's a big discussion too, and a very worthwhile one. Because people, you talk about heart attacks and and people are like, yeah, okay, and then you talk about strokes and people get a little more scared. Then you talk about dementia and everybody's listening, nobody wants that. So that's definitely a worthwhile discussion.
Yeah, awesome. Yeah, because we have to look at the risk and benefits in the big picture, not just that one organ, right? Yeah. It's important, but you look and you go, okay, what's the effect on everything else and quality of life and all that? So Josh, such a blessing to have you. Thanks so much. Tro's going to be bummed. I'm kind of feel sad for Tro. He had some patient stuff he had to take care of, but he's going to listen to this and go, gosh darn, I wish I could have been there and asked questions. He wouldn't have liked the gut microbiome part that much. He gets a little ticked about that part of it, but otherwise he would have liked the cholesterol.
It's super fascinating. And honestly, I think there's just so much that's still on, for me too, to learn about the microbiome. And anytime there's something that I can hopefully immerse myself in and learn something to hopefully help the people I love, that's awesome. And so, I'm all for it.
Take all the tools you got, man. Relax, do your thing. So, hey, man, blessing to have you. Thank you so much for joining me. Hopefully we can get this out pretty quick, but awesome to have you.
Yeah. Thanks for having me. Hopefully we can do it again. And maybe even tag team it with Austin or something to really get in the weeds on some of these studies.
Yeah. Sounds good, man. Let's do it. It's a date.
All right, man.
All right. Have a good one.
You too.
Bye-bye.
If you enjoy the show, please consider supporting us on Patreon by going to lowcarbmd.com.